And ma- majority of our patients that comes to the echo lab comes with some assessment of coronary artery disease. So it's fitting that we spend some time on coronary artery disease, looking at how these patients present and what you're gonna look for when they come to the echo lab. So we're gonna go over the definition for coronary artery disease. We're gonna look at the normal coronary anatomy. Also, when we look
The
at
image is not on the screen, though.
so when we do the normal coronary anatomy, then we'll go over segments, uh, regional walls. We're going to look at some of the clinical presentation, risk factors, how we use echo to diagnose the different presentation of coronary artery disease. We're going to spend some time on myocardial performance index, MPI, or so-called TI index. Look at DPDT, which is an assessment of ventricular contractility, and then some of the mechanical complications of myocardial infarction. So let's move right into it. So we have discussed the pathophysiology of coronary artery disease before. And what we said is that the normal blood vessel lumen is smooth, without any lumps and bumps. But when you develop atherosclerotic plaques, then the wall or the lumen become lumpy, bumpy, and this can get significant buildup, and you get what we call stenosis. Or if the plaque bursts, then you can get clotting on top of the plaque, and the patient can present with acute coronary syndrome. And we talk about acute coronary syndrome, STEMI, non-STEMI, unstable angina, and sudden cardiac death. So if you remember, we discussed all of that. So again, the pathophysiology of coronary artery disease is the buildup of atherosclerotic plaques in the epicardial blood vessels. These are the blood vessels around the heart, so-called coronary arteries. And either by gradually building up of the plaques, it results in reduction of blood flow. And again, when the plaque ruptures, we talk about a vulnerable plaque. That is a plaque with a thin cap or a high lipid content. And those are the plaques that tend to rupture, and you have blood clotting on top of it, giving rise to acute coronary syndrome. So these are the blood vessels around the heart. So, the left main coronary artery comes off the left coronary sinus, and the left main coronary artery divides into a left anterior descending coronary artery, which runs down the front of the heart and loops around the apex of the heart, and then the circumflex, which loops around the back of the heart, so left circumflex. And then coming from the right coronary cusp is the right coronary artery. So when these blood vessels develop atherosclerotic plaque, then you get symptoms related to the territory that you have reduced blood flow. So you may have obstruction to the right coronary artery. So it's going to affect the muscle supply to that area, the muscles of that area. And then the LAD and circumflex, if you have occlusion of those blood vessels, then the territory supplied by by those arteries will be affected. So just looking, we said the circumflex loops around the back of the heart, okay? And the back of the heart looks like that. Okay. All right, so again, The normal blood vessel have a smooth lumen. The walls are, relatively thin. But when you have plaque development, again, we said that the oxidized LDL, which is the bad cholesterol, is taken up into the media by macrophages, and then these macrophages eat up the oxidized LDL. The process continues. You get initially what we call foam cells, and then these foam cells gradually build up to give you atherosclerotic plaque. You can have hemorrhage into the plaque, or you can have rupture of the plaque with clotting on top of it. Those processes gives rise to enlargement of the atherosclerotic plaque, and then you can have, the plaque can burst. We talk about a vulnerable plaque. A vulnerable plaque is one with a thin cap, a high rich lipid content. When the plaque ruptures, it releases materials which allow blood to clot on top of it, and can completely obstruct or occlude the lumen, giving rise to acute coronary syndrome. So again, acute coronary syndrome is your STEMI, ST segment elevation myocardial infarction, and your non-STEMI, non-ST segment elevation myocardial infarction. You can have your unstable angina and your sudden cardiac death. So, so the presentation can be varied. So you can have plaque without any significant obstruction. You can have plaque with significant obstruction. We usually talk about a 70% occlusion. It's usual for a plaque below, which is less than 70%, to not cause any significant flow obstruction. But plaques which are 70% or more will cause flow obstruction, and patients will present with angina. Okay, so especially if we do cardiac cath, the patient, you might do the cardiac cath for some other reason, and then you see some plaques all over the place. However, the patient may present with a myocardial infarction, and when we talk about myocardial infarction, we talk about your STEMI and your non-STEMI. STEMI is when you have the ST segment elevation myocardial infarction. It's just an acronym for ST segment elevation myocardial infarction. And then your non-STEMI is your non-ST segment elevation myocardial infarction. So the patient is having a heart attack, and in the STEMI, when you look at the ECG, you have ST segment elevation. And your non-STEMI, the patient is having a heart attack, and when you look at the ECG, it can be normal, or you may get ST segment depression, T-wave inversion, or some other EKG changes or ECG changes. So again, when we talk about angina, you can have stable and unstable angina. So your stable angina is if the patient develop chest pain after they walk 1 block, and they constantly develop chest pain after they walk 1 block. Whereas your unstable angina, if they used to develop chest pain when they walk 1 block, and now they're developing chest pain when they walk a half a block or less than that, or the pain is getting more frequent, associated with less activity, that's what we call unstable angina. And again, with sudden cardiac death, the patient dies. Sometimes, if this occurs in the hospital, then you can resuscitate them, or if it is witnessed, sometimes you can resuscitate them. So it's a resuscitated sudden cardiac death, and you can abort the death. But if this is not treated immediately, then the patient dies. Okay, then heart failure, if you have significant blockage. So if you have significant blockage of say, the LAD or multiple blood vessels, it can weaken the heart muscle, and the patient can present with systolic dysfunction. You can also have significant obstruction to multiple blood vessels around the heart, and then the patient can also develop diastolic heart failure because the heart becomes stiff non-compliant. Some of the risk factors for coronary artery disease, patients will develop blockage if they have these risk factors, older age. So the older one gets, the greater the risk of developing coronary artery disease. Smoking is a very big risk factor. Dyslipidemia, high cholesterol, or a low HDL, a low good cholesterol, a high bad cholesterol. Those are features. Hypertension is another risk factor. Diabetes mellitus, obesity, and a family history of coronary artery disease. We can risk stratify these patients, and if you remember, we talk about the TIMI risk score, the GRACE risk score, or you can use the Framingham score. Framingham score, look at the patient's age. This give you the risk of developing coronary artery disease. So the Framingham risk score give you the risk of developing coronary artery disease, where your TIMI and your GRACE is when the patients have an acute event. You can risk stratify them. So for the Framingham risk score, we look at the patient's age, total cholesterol, HDL, which is the good cholesterol, smoking history, yes or no, systolic blood pressure, and diabetes mellitus. We plug these into a table, and then we can give, the risk, whether it's low risk, high risk, or intermediate risk. How do we use echo to assess coronary artery disease? So echo is a very crucial echo plays a very crucial role in the assessment of coronary artery disease, because remember what we said, you can have both diastolic and systolic dysfunction. So you can evaluate the systolic dysfunction, you can evaluate the diastolic dysfunction. We can look at the ejection fraction, wall motion abnormality. So the echo is crucial in the assessment of patients with coronary artery disease. This is a patient with LV systolic dysfunction, so you don't have to know anything about echo. You know that the systolic function is very depressed. So this is a patient that may present with heart failure. Okay. If you look at that, so that is the parasternal long axis. This is the apical four-chamber view. And you can see this ejection fraction is probably 20-25%. So, one of the most common cause for depressed LV systolic function is coronary artery disease, blockage of the blood vessel around the heart. All right. So, and then when you look at your mitral inflow, you may see evidence of elevated left ventricular filling pressures. We talk about your EE prime. So if your EE prime, the medial, is greater than 15, it suggests elevated left ventricular filling pressures, which is one of the features of heart failure. All right. If the patient, and we can grade diastolic dysfunction by looking at your EE prime, okay? And so your E to A and your EE prime, we can use that. If, of course, you can look at valvular lesions associated with that. So this is your two-chamber view. So depressed LV systolic function. So echo is very important, and just your resting to the echo is a very important assessment to see whether the patient have a systolic or diastolic dysfunction. Now, stress test is a very crucial tool to assess coronary artery disease as well, because patients may present with less classic symptoms. If the patient presents with classic symptoms of coronary artery disease, then you don't need to do a stress test. You take the patient straight to the cath lab, and you can evaluate them using cardiac catheterization. However, if the symptoms are not very clear, atypical chest pain, angina equivalent. Then you can go on to a stress test, and then the stress test will tell you yes or no if the symptoms are due to coronary artery disease. When we do stress echo, we can do what we call exercise stress echo or dobutamine stress echo. And when we talk about exercise stress echo, we can do the treadmill exercise stress echo or a bicycle exercise stress echo. You can also do dobutamine stress echo. Okay, so these are the common ones that you can do. Now we're gonna go over the the regional walls and then the blood supply to the regional wall, because when we talk about coronary artery disease, we talk about blockage of the blood vessels around the heart, and if we know the region or the segment that the blood vessels supply, then when we look at the echo, if you have wall motion abnormality just in that area, you can predict the blood vessel that's occluded. So when we look at the apical short axis view, we have the anterior wall, the inferior wall, the lateral wall, and the septum. Okay? It's usual that the inferior wall is supplied by the RCA, usual, and the apex and the septum is supplied by the LAD. Okay? The lateral wall is usually supplied by the left circumflex. So at the mid cavitary level, short axis, of course, the anterior wall, the inferior wall, this is the lateral wall, but lateral wall is divided into anterior lateral and an inferior lateral. The septum is divided into anterior septum and the inferior septum. So again, the anterior and the anterior septum is usually the LAD, okay? The inferior and inferior septum is usually the RCA, right coronary artery. And then the lateral wall is usually supplied by the left circumflex. And then at the basal level, okay, at the basal level, you have the anterior wall, inferior wall, the lateral wall, and the septum. The lateral wall is divided into anterior lateral, inferior lateral. The septum is divided into anterior septum and an inferior septum. Again, the anterior and the anterior septum is the LAD, okay? The inferior septum and the inferior wall, RCA, lateral wall is the left circumflex. So it's relatively simple. Anything up top and to the side is the LAD, anything down bottom is the RCA, and anything to the lateral is the circumflex. So just if you understand this basic distribution, then you'll get about 90% of these correct. The apex of the heart is usually supplied by the LAD. Okay, so again, when you have obstruction to these blood vessels, it's going to affect the walls that they supply. All right. So when we do stress tests, we have a system to interpret the stress test. So if your resting 2D echo shows a normal segment or regional wall, okay, and then when you do your stress echo, if you look at that same segment and it's hyperdynamic, then that's a normal segment. That is what's supposed to happen. When you exercise someone, you're supposed to get increased motion, increased thickening of a normal segment. Okay? However, if you look at a normal segment at rest, so you do your echo at rest, and the segment is normal, and then you stress the patient, and that segment becomes abnormal. And we usually talk about hypokinetic, or sometimes it might become dyskinetic. If you see that in your echo, then that's what we call ischemia. What happens is when you increase the demands on the heart, because you have an obstruction, the heart cannot supply enough blood to match the demand, and that area of the heart does not move properly because it needs more blood, it needs more nourishment to perform normal. Okay, so normal at rest, abnormal with stress, that's ischemia. If you look at the wall at rest and there's abnormality at rest and it's worsened with stress, then that's also ischemia. You cannot supply enough blood to match the increased demand. So that's ischemia. If you have abnormality at rest, you do your echo, it's abnormal, and it's unchanged. That is what we call infarction. And remember, infarction is dead muscle. So dead muscle cannot do anything. When you're dead, you're dead. So if the muscle is dead, you can increase activity all you want. The muscle cannot. There's not going to be any thickening. There's not going to be any increase motion of the dead muscle. But of course, if you have tethering, and again, tethering is when the normal segment pulls the abnormal segment and gives it the appearance that it's normal. So be aware of that. Again, if you have an akinetic segment, there's no thickening at rest, and then at stress it becomes dyskinetic. That again, infarcted muscle. Okay. When you look at the resting echo, if there is wall motion abnormality and you have a biphasic response, that usually you get a biphasic response with dobutamine. It suggests that there is valvular myocardium. And how this works is, say for instance, the patient have an ejection fraction of say 30% at rest, and you're looking at a segment. So you look at the anterior wall, and the anterior wall is hypokinetic with low dose dobutamine, because when we do dobutamine stress echo, we start with low dose. We'll start at 5 micrograms per kilogram per minute. Then we go to 10 micrograms per kilogram per minute. Then we go to 20, we go to 30, 40. Some protocols go to 50. Low dose dobutamine is up to about 20 micrograms per kilogram per minute. So if it's abnormal at rest and with low dose, you get increased, say, thickening or increased motion. And then at the peak of the dobutamine, it becomes akinetic again, or hypokinetic, not akinetic, but hypokinetic with peak. Then that's what we call a biphasic response. So it increased with low dose, and then it go back to being abnormal at peak or high dose. That's a biphasic response. And what that is telling you is that even though you may have say a 30% ejection fraction, there are some muscles that are still alive, are still viable in that 30%. It's not all the muscle that is dead, because as we mentioned before, dead muscles do not contract. Okay, dead muscle is not going to increase its activity because it's dead. However, if you have what we call hibernating myocardium, so when we talk about hibernating myocardium, what's happening is you have a low flow state because of the obstruction, and the muscle function decrease because of the low flow state. But once you increase the blood flow, the muscle start functioning normal. That is what we call hibernating myocardium. So you get a reduction in the ejection fraction because of the low flow state. But once you improve the blood flow, the function gets back to being normal or fairly normal. So these are patients that would benefit from stents or bypass surgery. So you have to identify them. So not all patients with 20 and 30% ejection fraction have all dead muscles there. some of the muscles are hibernating. Okay, so you have to devise a test to prove that some of the muscle is viable. And that's crucial because if you take someone with, say, a 20% ejection fraction and majority of the muscle is dead, and you do bypass or stenting, the patient may deteriorate or, as opposed to improve. So you have to, as a matter of fact, when you have an ejection fraction that low, 20, 30%, you almost always have to do a viability study to show that there are viable muscles there. You don't want to revascularize the patient and then the patient deteriorate on you. Okay, so with the dobutamine, you get the biphasic response. So with the low dose dobutamine, you have improvement, and then with the peak dose dobutamine, you have worsening. Okay, it suggests that they're viable muscle there, so you can go on to do your stent or your bypass surgery. And then the last category is the patient have an abnormal wall motion at rest, and it improves with stress. So this is just a cardiomyopathy, a non-ischemic cardiomyopathy. Okay, wall motion abnormality at rest, and it improves with stress. It's a regular cardiomyopathy. So I recommend that you know this table fully, so you can interpret your stress echoes. All right, we're gonna look at what we call myocardial performance index, the so-called TI index, and we did look at this when we did the right side of the heart. Now we're gonna look at it for the left side of the heart. So the MPI, or the so-called TI index, it assesses the overall LV function, both systolic and diastolic. So it's not just a diastolic assessment or systolic assessment; it assesses everything. And you need PW measurements, okay? And the full description of this is left ventricular index of myocardial performance, and you need to know the definition. So we did it when we did RIMP, when we did right heart, and for the left heart it's called LIMP, left ventricular index of myocardial performance, the so-called TI index. Okay, so what we do, and it's a simpler test. It's simpler if you're doing it on the left side as to the right side. So when we're doing LIMP, you put your sample volume of the mitral leaflets, apical four-chamber view, and you put your cursor sample volume at the mitral valve leaflets, and the definition for LIMP is mitral valve closure to mitral valve opening minus ejection time divided by ejection time. So essentially the same definition that you use on the right side. Okay, so LIMP. Okay, it's done. So pulse wave Doppler assessment, apical four-chamber view, cursor is across the mitral valve. The sample volume is at the tip of the mitral leaflet. The definition is mitral valve closure to mitral valve opening minus ejection time divided by the ejection time. Okay, so this is the definition: mitral valve closure to mitral valve opening minus ejection time divided by ejection time. Well, as you will see in the next slide, mitral valve closure to mitral valve opening minus ejection time is just your IVCT plus IVRT divided by ejection time. And this is how we get it. So if you put your sample volume across the mitral, the tip of the mitral leaflet, you'll get your mitral valve opening. Remember, the mitral valve opens in diastole. Okay? When the mitral valve closes, Okay? When mitral valve close, before the aortic valve opens, you have your isovolumic contraction time, and then the aortic valve opens, and then you have ejection across the aortic valve, then the aortic valve close. Then before the mitral valve opens, you have your IVRT, isovolumic relaxation time, then the mitral valve opens, okay? So again, the definition is mitral valve closure, the mitral valve close right here, to mitral valve open, and mitral valve opens right there. We're going to subtract from this the ejection time. So when you subtract from the mitral valve closure to mitral valve opening, the ejection time, you see you're left with isovolumic contraction time plus isovolumic relaxation time. And then you're going to divide by ejection time. So all you need to calculate LIMP, all you need is your IVCT and IVRT and your ejection time. Okay? So you have to know the definition. You need to draw this and fully understand it. So mitral valve closure to mitral valve opening minus the ejection time. So when the aortic valve opens, blood starts to be ejected from the aortic valve all the way to the maximum ejection, then it closes right there. So this is the total time it takes. Okay. So again, isovolumic contraction time, isovolumic relaxation time. So the normal LIMP value is about 0.39 plus or minus 0.05. So again, it's an assessment for overall myocardial performance, both systolic and diastolic function. It increases in patients with all spectrum of heart disease. So it's a larger number in patients with heart disease. We look at RIMP before, and it's important to follow patients with primary pulmonary hypertension. All right, so we're let's stop here. We're gonna stop right here, and then the next session we'll do DPDT and complications of myocardial infarction. So